Hello, everyone. This is the New York City Department of Health and Mental Hygiene update on COVID-19 for New York City healthcare providers. Thank you for joining today's webinar. Please note that you have been placed in listen-only mode. If you have any questions during the presentation, please submit them via the Q&A portion of the WebEx, and we will address them as time allows. Joining us to present the overview today is Dr. Madhuri Ray, Critical Care Planning Lead for Healthcare System Support for the agency's outbreak response. And joining us for today's spotlight presentation on school health reopening considerations for providers are Dr. Cheryl Lawrence and Dr. Karen Greer from the Office of School Health. We also will be issuing a brief poll at the end of the webinar, and we thank you for your participation in that. It helps us to get a better understanding of what types of topics you would like us to be offering in the future. And as a reminder, this webinar will go until 2:30 so that we have ample time for presentations and questions. And with that, I will hand it off to Dr. Ray.
Thank you, everyone, and welcome to our webinar. Allison, could you please advance the slide? So today we have a really interesting presentation. We will, as usual, start with where we are now, including some updates from our surveillance colleagues, as well as some clinical updates and some interesting studies that have been in the news. And then a very high demand topic, the return to school information for medical providers. I'm sure all of you are getting a lot of questions from families, from parents, and we see some of them in our chat box. And so this is really your opportunity to ask as many questions around that topic as you would like. And of course, in the last section, we have questions and discussion. We have several links, and there's a lot of content in the slides. The slides will be up after the presentation, as well as a recording of this webinar. And advance the slide, please. So COVID cases around the world continue to increase, with more than 26 million cases worldwide and 873,000 deaths due to COVID-19. In most states, which is a little different from what we've been reporting, in most states, the daily U.S. case counts are decreasing. And, this is in contrast to the resurgence in a lot of places in the country that we have been seeing in previous weeks. A case report has been released addressing a question that we talk about and ask about on these webinars almost every week, which is really, what does immunity to COVID-19 mean? And this case report from Hong Kong confirmed reinfection by COVID-19 by the SARS-CoV-2 virus in a patient from Hong Kong, and this is an immunocompetent patient. Additionally, in the news is that the FDA issued an emergency use authorization for convalescent plasma, which is new from the last webinar. And can you advance the slide, please? So again, we have over 26.5 million cases and over 873,000 deaths. You can see that the U.S. still has quite a bit of, in terms of cumulative, is still a good portion of the cumulative cases or all the people who have ever been diagnosed with COVID. And can you advance the slide, please? So within the U.S., again, we look at the cumulative cases and deaths, and we've got, sorry about that. We've got over 6.3 million cases in the United States, again, throughout the response. And we look at this percentage every week, which is what is the U.S. contribution to the total burden over time of COVID-19. And this number was at one point, this number was very high at one point. I think when we started presenting this, it was well over 30%, and now it's gone down to about 24%. So a quarter of the confirmed global cases ever in the world are cases from the United States. And then there are over 191,000 deaths from the United States, which represents about 20% of all of the deaths over time from COVID-19. And can you advance the slide, please? So another issue that we've had several presentations on is the multi-system inflammatory syndrome in children. And as you may remember, in April, the first cases were reported in UK and Europe, and there was a syndrome that appeared subsequent to SARS-CoV-2 infection in children. And this, given the proximity to COVID infection and the numbers of cases that we were seeing, we were investigating a causal link. So as of September 3rd, which is yesterday, there have been 226 patients in New York City who meet the definition for MIS-C from the CDC, and we have the definition listed here. There is guidance for evaluating MIS-C in ambulatory settings. So if you do see children with by children we mean anyone less than 20 years old, with a fever in the hospital, with multi-system involvement, and certain inflammatory markers that are very, very high, you should really think about the diagnosis of MIS-C, and that is a reportable condition. And so you would call the provider access line at 866-692-3641 if you encounter those. I encourage you after the presentation, when the slides are up, to review the diagnosis of multi-system inflammatory syndrome in children if you see children in your offices, and if you need a refresher on those criteria. Can you advance the slide, please? And now we have a couple of contrasting studies here that have recently been released from the MMWR, the CDC MMWR. And what this shows is, around the question of children being together in a group setting, and this is in the context of overnight summer camps. So the first story, or the first picture we'll paint, is from Georgia. So Georgia is a high transmission state, and over the period that this study covers, transmission was very high throughout that time in Georgia. So there were 597 attendees at this camp, and what you can see is they didn't, a lot of the core, what we call a multi-layer approach to preventing transmission of COVID was not really followed here. And so face coverings were not worn universally, and adherence was not very good to wearing face coverings. There was no testing after arrival. And then both indoor and outdoor activities in the study, there were a lot of activities that we think may increase exposure between camp members, such as singing, cheering, other things that may theoretically increase the amount of virus expelled by a person. And, especially asymptomatic persons may not understand that they need to escalate. So there's a 44% attack rate in the study, and these are all these are, mostly young persons at this camp, though there was a wide range of ages in terms of everyone present. But what you can see is that as the length of stay at the camp increased, the attack rate increased, and there was a really important impact of asymptomatic transmission. And so there is some question about whether young people are going to transmit COVID, whether they will transmit it to adults. And in Georgia, this case rate says that it really does seem that being in these congregate settings, not employing the multi-layered approach, with the duration of all those activities outside of this multi-layered approach in this setting, do increase the attack rate of COVID. And can you advance the slide, please? So here's a different picture. So, in Georgia, we saw really that being at camp was associated with very, very high transmission of COVID. However, in Maine, during the duration of this study, the transmission rate of SARS-CoV-2 was very, very low. And you can see that the number of attendees here are even greater than the number in the Georgia camp, so 1,022 attendees over a period of 6 to 8 weeks. But you can look at there's a series of interventions that were implemented in Maine. One is the face covering. So everybody was required to wear a face covering. Pre and post arrival testing and isolation. Before arrival, everyone was tested before arrival. Suspected cases were asked to delay arrival. Upon arrival, camp members were isolated until until they were pretty sure that nobody was asymptomatic but positive for COVID and could transmit the virus. The activities were, gathering and close contact were limited. Overall, throughout the 6 to 8 weeks, indoor activities were limited, and symptoms were monitored daily. Other physical distancing measures on a larger scale were implemented, such as staggered dining and, of course, bathroom use. So in the end, only 3 COVID cases were identified, which is a 0.3% attack rate relative to the 44% attack rate that we saw in Georgia, and there was no secondary transmission. So all of the transmission occurred from things that occurred from events outside the camp. And so this really does say that, there is a danger when young people are in a large group together. It's not something that is automatically safe. However, employing a multi-layered approach of non-pharmaceutical interventions and testing appropriately can really bring that case rate down and reduce that risk extremely significantly. And can you advance the slide, please? So for the next piece, we are just going to talk about the restrictions that you may have heard about around out-of-state travel. And so for a list of 33 states and territories that meet criteria, the criteria being a 7-day rolling average percent positivity in testing of less than 10%, greater than 10%. So we've talked about percent positivity a little bit before, but percent positivity means of the people getting tested, how many are you catching that are positive, and we're assuming widespread testing. And so number of 10% would indicate a really high transmission rate of COVID. Or alternatively, a case rate of greater than 10 out of per 100,000 residents. And so either of these just are markers or proxies for the transmission rate being very, very high. And so the restrictions, if someone is coming from one of those states and entering New York State, is to quarantine for 14 days. And so what does that mean? So the quarantine means regardless of symptoms, regardless of whether there is a known exposure or not, individuals cannot go out in public. They are encouraged to self-quarantine from other family members, even if they're in the same household. New York State will provide phone reminders of these quarantine, of the sort of indications and what you should do when you're in quarantine. But then, of course, this doesn't apply to every situation. So if you're passing through a state for less than 24 hours, this doesn't really count. So let's say you're going to an airport and the airport is located in a high transmission state, but you're only there to get from one flight to the next. In that case, you would not have to quarantine. And can you advance the slide, please? Another exemption to the quarantine. So we've said that, short short travel. Although you should, try to, of course, maintain all of the other suggestions that we have to prevent transmission, including wearing a face covering, maintaining physical distance, and washing your hands. But of course, outside of that, there is no restriction if you're there for less than 24 hours. Additionally, essential workers, including first responders and healthcare personnel, can work even if they have traveled to one of those states recently. Everybody, though, even though they are allowed to work because their work is deemed essential, are advised to minimize contact with others, including self-monitoring for COVID-19 symptoms. Of course, if a person did feel that they had COVID-19 symptoms, they should, of course, isolate at home and not attend work. But as always, wear a face covering and observe hand hygiene and maintain physical distance as much as possible. So if someone who is an essential worker is traveling to New York State from one of those states or territories where high transmission is occurring, and the duration of stay is over 36 hours, persons are advised to seek diagnostic testing within 24 hours of arrival, meaning that, at that point, if you're going to stay long enough to get the results of the test, it's a good idea to get the test as soon as you arrive, and of course, maintain physical distancing, self-monitoring, and expanded hygiene practices. But really, and this is really trying to be extra careful about that, and so physical distancing, even within the home, even among others, and that's for 2 weeks. And then of any extended periods in public or in any congregate settings, you're advised to avoid those for at least a week. Different industries have specific industry level guidance, and those are available on the link below, or you can consult your employer. The New York State interim guidance is listed at the bottom in a PDF. And can you advance the slide, please? Finally, we have an ongoing shortage of blood supply. There's been a decrease in blood drives as many persons are working from home, and we want to limit outdoor activities. However, at this point, it is safe to present for blood and plasma donation. There really is an urgent need for red blood cell. Additionally, convalescent plasma, which I mentioned in the beginning, recently was authorized under an emergency use authorization by the FDA. We do need donors for convalescent plasma, and of course, as a provider or as a citizen, we encourage everyone to help organizing and promoting self-blood drives. I think as a provider, if you speak to your patients about that there are safe ways to donate blood, I think that patients will feel confident and will probably be more likely to help with this effort. And of course, any individual who is eligible can donate at New York Blood Center donor sites. The link is available in the slides. It will be available after the presentation. And can you advance the slide, please? I'd like to turn it over now for school to hear about return to school information for medical providers to my colleagues, Dr. Lawrence and Dr. Prater.
Thank you, Dr. Ray. Can you hear me?
Yes.
Great. So we've been receiving a lot of flurry of inquiries from the provider community, the pediatric provider community, about school reopening. And we know that this is a hot button topic. So we wanted to make sure that we address as many of the concerns. So what we tried to do is, since this topic is continually evolving, we wanted to provide you with the responses that are accurate as of now. Anything that's still evolving, we will mention that as we go through the slides. But we know as pediatricians ourselves, the importance of having all of the information as best you can to support your patients. So Hopefully you will find this helpful. And here we go. Next slide, please. So today what we're going to go over is the school reopening plan. This has been a very long, I can't stress that enough, process, daily meetings, and it's still happening. So, but a tremendous effort has been placed in the reopening plan. The next thing that we'll be talking about is the return to school preparation for all of you. We want to be able to provide you with some information and actually answering some of the questions that you have shared over the last few weeks. Then next, we will talk about school health specifically, some of the clinical services and that many of you interface with, and we want to give you updates as to what that would look like in this new setting that we're in. Lastly, we will spend some time talking about the clinical evaluations that will be occurring in the schools for your patients. And then at the end, we will discuss some anticipatory guidance. Next slide, please. So, school reopening plan, here we go. So this, I think it's always helpful to have a timeline to go back and to understand where we started, and so we can get a better sense of where we are today. So if you can recall, back in March, the first case of COVID was identified March 1st. Then March 16th, schools were closed due to the COVID-19 pandemic. And as soon as schools were closed, there were plans already in place to start preparing for the reopening of schools. By March 23rd, the regional educational centers, which are known as rec centers, were open to support families and frontline essential workers with childcare. By April 11th, New York City declared students will continue in the virtual learning for the rest of the year. And during that time, plans were still ongoing in terms of reopening and what that would look like for the fall. By May 1st, the governor declared schools across New York State will be closed throughout the end of the school year. New York City Department of Education, by July 7th, submits the preliminary school reopening plans to New York State. By July 12th, DOE launches a school reopening website plan, the Return to School 2020 that many of you have read. By August 7th, the deadline for parents to submit their survey regarding their learning preference was in place, and Governor Cuomo approved the reopening of schools as of August 7th. By August 14th, 1,200 schools submitted school schedule plans. And then just recently, September 1st, the decision was made to delay in-person learning until September 21st, and remote learning will begin on September 16th. So a lot of this, you will notice, focuses on the DOE plan. So I just wanted to share that caveat, but that is the timeline that has been occurring thus far. Next slide, please. So there were a few guiding principles that DOE had to really take into consideration when they were planning the reopening. First was the physical and mental health of the students, teachers, staff, and family. There is a tremendous focus on the trauma-informed care model, which we'll discuss a little bit more afterwards. There's greater equity among students with respect to the education they receive and the learning environment in which they receive it. Academic achievement is a major focus through high-quality instruction, tailored enrichment, and culturally responsible education practices. Knowing that students and staff are going to be coming back into the building, it is critical to acknowledge the social and emotional and the trauma-informed support for all students and the entire school community. community and continuity all year long among students, teachers, and staff. So these were the concerns that needed to be addressed. And when you're dealing with when you're dealing with nearly 1 million students, this is a huge undertaking. Next slide, please. So students were given an option whether they wanted in-person learning, virtual learning, or blended version of the two. And based on the various models, if they had a blended version, they would be in school certain days. And this would allow the Department of Education to maintain students in a cohort. And this is for tracking purposes. So if a student is assigned to the blended model, or even the in-person learning permanently, but they're assigned to a particular room, particular day, so that if there's any positive cases, they can easily track and know who potentially was in contact with that individual. The information will be shared with all important parties as to where that student is, whatever day of the week. And that's, like I said, critical to the tracking and for any potential tracing that needs to take place. Next slide, please. So this is from the New York State guidance, and these are the thresholds for school opening and school closure. We know that in the spring, our positivity rate was quite high, and thankfully, New York City's positivity rate it has lowered and is amongst the lowest in the country. But for school reopening thresholds, in order for schools to open, New York City must meet the following. The percentage of positive cases in New York City must be less than 3% using a 7-day rolling average. If we cross this threshold, schools will not open. So we have between now and later this month when schools reopen, and this is closely being monitored. Now, once schools open, we have a different monitoring system that we'll be using. Schools will need to close if New York City meets the following. If the percentage of positive tests in New York City is equal to or greater than 3%, using a 7-day rolling average. This will cross, if we cross this threshold, schools would absolutely need to close. Next slide, please. If there is one or more confirmed COVID-19 case in a single classroom, all students in that classroom will convert to virtual learning for 14 days. If there are 2 or more students with COVID-19 diagnosed within a 7-day period of one another with known association with any person with COVID or with each other, the entire school building will convert to virtual learning for 14 days. Students with confirmed positive testing cannot return for 10 days and must be fever-free without medications for 24 hours and have improving symptoms. So this is being very closely monitored. This will be very closely monitored. And there is a very extensive plan in place to know exactly, as I mentioned before, when I mentioned the cohorting of students, when they're in the building, there is a very systematic plan in place to be able to monitor and address these 3 points. Next slide, please. Students, families, and school staff should monitor for signs of illness. School-based staff and schools cannot report to school if they have any of the following. If they experience any symptoms of COVID-19 during the past 10 days, had a positive diagnostic test for COVID-19 during the past 10 days, were knowingly in contact with anyone who's had a positive diagnostic test for COVID during the past 14 days, or traveled internationally or from a state with widespread community transmission of COVID per the New York State Travel Advisory in the past 14 days. Next slide, please.
Hello, everyone. The plan for daily health screenings for students and school-based staff is still evolving, and the details are still under discussion. As of today, students and staff who are strongly encouraged to have testing and will be given resources for prioritized testing at locations throughout the city, but at this time, they are not required to be tested. Next slide. If a student exhibits symptoms of COVID-19, they will be evaluated by a school nurse in the isolation room. If a school staff member develops symptoms of COVID-19 while at school, they will be asked to leave the building with strong encouragement to seek medical evaluation for their symptoms, including getting tested for COVID-19. Next slide. So this slide identifies what is known as the core four. These are the key components included in messaging geared to New Yorkers towards preventing the spread of COVID-19, encouraging New Yorkers to stay home if they are ill, to maintain 6 feet of physical distance when in shared spaces, to practice good hand hygiene, and to wear facial coverings. The core four will have implications for school reopening because they are part of the foundation for promoting a safer school environment. We've already talked a little bit about students who are ill, reminding parents and families to stay home and for staff to stay home if they are sick. We'll talk about the next 3 actions over the next few slides. Next slide. So physical distancing will have a significant impact on schools and classroom capacity for in-school instruction. All individuals must stay at least 6 feet apart in common areas of interactions in school. And that includes at building entry, during movement through hallways and stairwells. There will be created single file routes and one-way direction stairwells to sort of guide the flow through hallways and staircases. Of course, during classrooms, they will be spaced 6 feet apart. Anytime they're in a shared space, which includes gyms, cafeterias, auditoriums, and playgrounds, in elevators and bathrooms, at dismissal, and also during transport. Signage and floor markings will be in place to provide reminders, guidance, and reinforcement of the physical distancing principles. Next slide. School staff will be placed in high traffic areas to ensure that students are adhering to the physical distance guidelines. To reduce movement, teachers ideally should travel from class to class while students remain in the same room throughout the day to the extent possible. Whenever possible, students should remain in those cohorts. In addition, physical barriers will be constructed in the main offices. Visitors will be limited, and it's recommended that student drop-off and pickup is done outside of the building, for example, to minimize the number of external visitors. Lunch will be served in classrooms. If the cafeterias are used, proper physical distancing procedures will be maintained. Next slide. The next core action has to do with wearing a facial covering. Use of face coverings while in New York City Department of Education buildings is mandatory, with the following exceptions. Students who cannot tolerate a face covering for medical reasons, or students for whom the use of such coverings would impair their physical or mental health. Any child who's less than 2 years old in the school building. And there will be modifications made for certain students, for example, students that have hearing impairment or hearing loss, or students receiving language services. Facial coverings with vents or valves are not allowed at school. New York City Department of Education will have face coverings available on site for all staff, students, and essential visitors. Next slide. There'll also be an emphasis on the next core action, which is good, consistent hand hygiene. Students and staff will need to thoroughly clean their hands as soon as they enter the school building, between classes, before and after physical education, and before and after meals and snacks. Age-appropriate lessons have already been developed to teach students about hand and respiratory hygiene. Hand sanitizer dispensers will be installed throughout all school facilities to encourage a good hand hygiene, and posters and signage will also be placed throughout schools to reinforce the importance of these practices. Next slide. And in terms of cleaning and disinfection, the Division of School Facilities has a cleaning protocol that follows both CDC and New York State Department of Health guidance, including procedures to perform in the event of a confirmed case of COVID-19 in a school. Schools will ensure that they have the adequate amounts of cleaning and disinfection supplies. They will ensure deep cleanings are completed on a nightly basis, including the use of electrostatic sprayers. HVAC improvements are underway to ensure proper ventilation. Schools will implement improved cleaning of classrooms, bathrooms, and high-touch surfaces, such as doorknobs and shared equipment like computers, which are used more frequently. They will also provide cleaning supplies for classroom teachers if requested. In terms of the school health medical room, we have our established protocols for cleaning and disinfection that we will adhere to. Next slide.
So we know that the toll that COVID has had on our community has not excluded the impact on students. We know that for everyone entering the school building this fall, there are a lot of issues and concerns that have to be dealt with. So DOE has planned to create a model of healing-centered schools. And this plan is for students and for school staff to maximize consistency in relationships, schedules, and routines while creating a space for reflection and healing. So the healing-centered schools is going to be a major focus for the fall and for this school year. And this will create a trauma-informed care model, including a bridge-to-school program. It'll use the first few weeks of school as a stabilization period. And this will be really focusing on the new structures, the new routines, identifying and uncovering some of the social emotional concerns that everyone may have, and creating a space for emotional safety and stability. We'll also allow the students to build coping skills, process their recent experiences, and establish or maintain emotional consistency. These healing-centered schools will strengthen school-wide implementation of proactive social emotional learning and instruction. And it will ensure that all DOE schools are able to provide direct mental health services on site. Next slide, please. So there are other health and safety programs in the schools that I just want to mention. So we also have the early childhood contracted programs, and some of you will likely have your patients or attendees. If they are attending before and after care programs, these programs must train their staff in all of the relevant and safety guidelines. The extracurricular and after-school program availability will depend on the level of risk of COVID transmission, if there are any modifications that are needed to mitigate transmission, and the form in which the activity will be possible. And of course, the level of interest of the students and families. So as of right now, it's hard to know exactly which programs will be available, but these are all of the considerations that are taking place to determine whether or not they will open. Next slide, please. So right now, there are lots of forms that you must complete, but the sports clearance isn't one that's needed right now, because as per New York State, all interscholastic sports programs are postponed. Students diagnosed with COVID-19 should be evaluated and cleared for sports participation by a physician. Next slide, please.
So at this point, we're going to talk about what our community medical providers can do to help prepare their patients to return to school. This is a quick provider checklist, which we will discuss in detail over the next few slides. Just a quick summary, providers should focus on completing annual well child care visits, follow up with students that have chronic diseases, ensure that their patients' vaccinations are up to date for school entry, complete the relevant school forms, and provide guidance to students and families that are preparing to go back to school. Next slide. So in terms of school entry requirements, you should consult the SH65, which is the agency's guide that's updated annually to share health screening and immunization requirements for school entry. It is available on the DOE website, and it talks about health screenings. So ideally, you should be reviewing that guide as you schedule catch-up visits or visits that were postponed during the COVID-19 peak, and use that guide to complete the relevant forms, and as we'll talk about later, for school re-entry. Next slide. I'm sure that by now you're familiar with the CH-205, which is the Child and Adolescent Health Examination Form. It's required for all new school entrants and children attending child care facilities. Students who entered school prior to the age of 5 years must have an additional form completed within 1 year of turning 5. One of the major changes this year that's noted on SH65 is that due to the COVID-19 public health emergency, the Office of School Health will accept CH-205 forms that include physical exams and screenings that were performed within the previous 18 months, realizing that some delays occurred during the peak of the pandemic. This will remain in effect until December 31st, but it may be revisited depending on the evolution of the pandemic. Please note that the Office of School Health cannot accept a CH-205 that does not include results of an in-person examination. Next slide.
So chronic disease management, excuse me. So we're just reviewing here some of what you already know, following up with patients with chronic diseases and really keeping them out of the ED so that they do not feel that they have to go elsewhere or go without their meds. Ensuring that they have their, reviewing their current medication management, ensuring that they have the appropriate medication supply at home, and making appropriate specialty referrals to ensure follow-up, and ensuring that their needs are met because, as mentioned before, their social emotional needs are quite different, And one of the things that we uncovered as we reached out to many of your patients just to follow up and see how they were doing, that their need for additional support and resources were quite heightened during the COVID-19 emergency. Next slide, please. So for immunizations, just want to share with you a follow-up. As Dr. Dreer mentioned, the SH65 has the current schedule, but we also wanted to provide these links to follow the CDC guidelines, and also the catch-up schedule, immunization schedule can be found, and the links are provided here for you. We also wanted to highlight the influenza vaccination, that while it's not required for school, but it is required for childcare. The vaccine, the CFC distribution has started, and you can now order if you're not aware. And so that's available and ready for everyone to order their supply. And the initial guidance that was sent can be found at the link that's mentioned below. Next slide. So I just wanted to talk about the medication administration form. This is something that's near and dear to our hearts. Hopefully it's near and dear to yours. So these are the forms that must be completed by providers to allow for medications and procedures to be performed during the school day. And this form, as per New York State law, must be completed by an MD, a DO, or NP or PA to allow the school nurse to administer medications or perform a procedure. Without that order, without your signature, they cannot provide those, administer those medications or perform that procedure. And I always like to highlight this is a really simple one, and especially now in light of the fact that students who may have asthma, this is a big one. For MAF to be completed, this will allow and prevent the nurse from calling 911 if a student has any type of respiratory concerns, respiratory distress in the school day. We provide the medications in school, and the nurse can have it in their hand, but they cannot. Their hands are completely tied. They're unable to provide that medication without your signature. So we do want to encourage that everyone completes the medication administration form for any of your patients that have a chronic disease. The other exceptions to when a medication can be given without a assigned order is if it's for epinephrine, because it's an emergency medication, or if it's glucagon. Laypersons can administer those medications without an order from a licensed provider. Next slide, please.
So all of the medication administration forms are available for the 2021 school year on the DOE website. The links for each of them are included here, including the general webpage known as Health Forms, for you to access them. You're probably already familiar with most of these forms, the allergy and anaphylaxis, asthma, diabetes, and general medication administration forms. We just wanted to let you know that we now have a new medication administration form specifically for seizures. Please use this form instead of the general medication administration form for students with seizure disorders that require medical intervention during the school day. Next slide. In terms of submission of forms, there are several options to submit completed forms. The traditional route was to give it to the school nurse on the first day of school. If that is the route that's chosen, please advise parents to give the form to the nurse instead of leaving it at the main office. This will ensure that the nurse receives it and can review it for completeness as soon as possible. For the diabetes medication administration forms, we have specific right faxes that are sent, that are secure faxes to send these forms directly to our central office for processing. There's already been guidance given to endocrinologists who submit these forms directly from their offices and have the fax numbers listed. For the other, previous slide, for the other MAS and CH205s, we have developed borough-based email inboxes. In order to submit it, you have to know which borough the student will attend a school in, and each borough has a specific MAS inbox that you can submit the forms electronically. Next slide. In terms of accommodations, providers can complete forms as well for students that have or require additional medical or educational support, including 504 accommodations such as testing accommodations or paraprofessional support through a 504 plan, transportation support for special education students, home instruction for students who can't attend school for medical reasons, and note that this is different from homeschooling. Requests for medical exemptions, and as a reminder, religious exemptions have not been allowed in New York State as of 2019. Requests for accommodations should be submitted to the student's school, IEP, or 504 team. And if the request is for a medical accommodation or is based on a medical diagnosis, the Office of School Health clinical staff will review these requests for medical necessity. And they may contact you if you requested an accommodation for additional information or clarification of the request. And also as a reminder, if medications or procedures are a component of this request, the relevant medication administration forms should be completed. Next slide. So we've talked about the preparation for return to school and the work that schools have done to get ready for our students to return. And we've talked about the work that you can do to help students transition back to school. Now we'll talk a little bit about the work that our team at the Office of School Health does. Next slide. So the Office of School Health is actually a joint program. It's a collaborative effort between the Department of Health and Mental Hygiene and the Department of Education. Our goal is to support and advocate for the needs, clinical needs, and educational needs of New York City students. We are known for providing our direct clinical services, which are the medications and procedures that we just talked about, but our nurses, nurse practitioners, and physicians also provide chronic disease management and case management. They provide health education and share resources to students and families. Our goal is to collaborate with our community providers who are the primary care providers and specialists for our students so that we can provide the best possible care to them. And we aim to establish connections with our community provider colleagues so that we not only have the information to support students during the school day, but we can also share clinical events and other information that could have an impact on or inform your management of your patients. So our clinical staff consists of the nursing team, which most people identify as school health. They are the daily presence in our schools. We also have clerical support staff that support us through the day, as well as our physicians and nurse practitioners who are assigned a panel of schools to manage. Next slide. With respect to our Office of School Health nurses and practitioners in our specific program, they do not serve as primary care providers. They serve as public health clinical managers. And as mentioned earlier, we collaborate with community providers to ensure that health needs are met in the school setting during the school day. Our physicians and nurse practitioners accomplish this by doing case management and follow-up, particularly for students with chronic diseases such as diabetes and asthma, which we'll elaborate on a little bit later. They also provide screenings and physicals as per the New York City Health Code for students who do not have access to care or a medical home, and we connect them to medical homes if needed. In addition, we have a reproductive health program that provides emergency and oral contraception to high school students. As the clinical experts and school health experts, our physicians and nurses provide support to our students and staff in their assigned schools. Lastly, our staff gives a variety of presentations to support and educate students, family, school staff, and local communities. Next slide. So of course, as you know, when schools shut down on March 16th, we could not provide those direct in-person services that we previously mentioned. However, we focused our efforts on providing support to our students and families through case management and health education, while the city's healthcare systems focused on building capacity to manage the COVID-19 pandemic during its peak. We made efforts to ensure that students maintain connections to community providers and medical homes. We provided select medication refills for students with asthma and students that had reproductive health needs. And we shared resources and provided referrals for families in need. And this was one of the things that we actually did the most work on during the peak of the pandemic, as families were trying to navigate what this meant for them and for their children who had chronic illnesses. Our goal was to keep children out of the emergency rooms and hospitals during the pandemic, and thereby assisted with flattening the curve. As the pandemic response evolved, we adapted our conversations with our families and students to ensure that they maintained their connection to their medical homes by encouraging well child and follow-up visits. Next slide.
So, next slide, please. So, as Dr. Greer mentioned, we cover the gamut of supporting all students with health issues. Our number one focus is to ensure health issues do not negatively impact academic performance. So wherever we can collaborate with you to ensure that your patients during the school day, their care is optimized, that's where we step in and work with you to be able to ensure that. There are two areas, there are two possibly that we, because of the sheer number, we tend to have a focus on. But we run the gamut. When you're dealing with as many students as there are 1.3 million kids, you are going to run across pretty much every single disease. But like I said, because of the sheer numbers, there are two disease processes that we deal with a lot, and the two are diabetes and asthma. We have over 2,000 students with diabetes that attend New York City public schools, and if we were to look at, and we also cover some non-public schools as well, and that number approaches about 3,000. We have something called the DMAF, and that's the Diabetes Medication Administration Form that was mentioned previously. It's the form that's specific to diabetes, and we've updated that form based on feedback from endocrinologists, pediatric endocrinologists throughout the city. So we have a new update. It seems like it's well received, and those have been working well to help improve the care of the students during the school day. As I mentioned, diabetes is one of the areas that we tend to focus on. So we are right now building a diabetes, an Office of School Health diabetes unit. And that unit will be comprised of an on-staff endocrinologist, pediatric endocrinologist, and we would have diabetes nurse educators that will help support the students during the day. And they're there to really provide support to the students and families. But our overall goal is, because of the nuances that are around diabetes and the number, it just appears to grow and grow and grow, the uniqueness in terms of the management and the various types of equipment that's out there, we felt that it was necessary to have a dedicated team that could provide enhanced support to those students. Next slide, please. So the next diagnosis that we focus on a lot is asthma. And asthma, by far and away, is probably the highest Right now, we know that there are well over 100,000 students that are within our schools that have, at least that we know of, that have asthma. We're sure that there's so many more. So we have a very comprehensive program in terms of how we manage asthma in our schools. So I alluded to some of it before, but I'll spend a little bit more time on it here. So during the school day, with the signed medication administration form that I mentioned before, we are able to administer rescue and maintenance medications throughout the day. The nurse is able to provide inhaled corticosteroids and also the albuterol. We offer inhaled ICS in the school, and we provide stock ICS and stock albuterol for free. All the parent needs to do is get a signed medication administration form from all of you, and then we can provide that to your patients throughout the school day. If you want your patient to have a different medication than what we provide, then yes, you can provide that as well. But more than 90% of the providers that we have been dealing with have opted to utilize the stock albuterol and the Flovent. Our comprehensive asthma program includes an asthma assessment, and that's done by our nurses and our physicians. There's asthma education. We have an asthma case management program where we have asthma educators available on staff. They're in select schools throughout the city, and they're able to provide a more intensive approach to look at all of the psychosocial needs of that student, and also work in collaboration with the families to ensure that the students receive the best care possible in school and out of school. And our program also involves collaborating with all of you and your patients to ensure that there is appropriate asthma management in our schools. We also have a pediatric pulmonologist on board that also assists with our more complicated cases and collaborate with community pediatric pulmonologists. Next slide. So we know that the symptoms of asthma and COVID may overlap. And that's really around the cough and shortness of breath. But part of what we are doing is to ensure that we want to ensure that students with asthma have appropriate level of control. We want to minimize their symptoms being confused with COVID-19. There's an isolation room. There are all these other places where students who have symptoms will go. But we do want to make sure that your patients with asthma that their asthma is well controlled to minimize any confusion during the school day. We do know that students with symptoms of COVID should not attend school. So that's why we want to emphasize the well control that's needed. We know that children with moderate to severe persistent asthma may be at higher risk for complications. So again, ensuring appropriate control, asthma control, and patients with asthma should not stop their prescribed ICS. This is one of the things that we had identified when we were calling some families, and it's also because of what was in the media. Some thought they had to stop their ICS because they had asthma, which was the exact opposite. So this is just something that we identified, so we're just sharing so that you can, again, continually remind your patients of this. Next slide, please. So nebulizer therapy. So we know that there are some students that some of you will like for them to receive a nebulizer treatment during the day in lieu of a MDI. So what we want to, but we also know that nebulizer use could potentially spread coronavirus to susceptible bystanders. In light of that, what we are doing as a program is that we are trying to avoid nebulizer use whenever possible. So as you write your complete your asthma MAS, and you complete your orders for your patients while they're in school, we want to encourage you to consider placing them to write an order for them to receive an MDI treatment. One, we know that it's faster, it's in and out, they can get back to the classroom. And the research does show that if a student is taking an MDI, it can be the same as a nebulizer treatment. So in light of COVID, we want to just emphasize this wherever possible. If a nebulizer use is absolutely necessary, because we recognize there are some that you may feel that they absolutely need to receive that treatment, it will be treated as an aerosol generating procedure. And the OSH staff person, likely the nurse, will need to administer that treatment in a separate room and will wear an N95 respirator. So I just wanted to just mention that, if at all possible, please, if they can, I just keep saying this, if it is at all possible, write their order for an MDI. Now, we recognize that there are some types of medications that must be nebulized. Of course, we know that, but when there is an opportunity to use the MDI, we want to try to use that as much as possible. Next slide. So Dr. Greer mentioned a little bit of this before, the accommodation reviews. This is another one of the clinical services that we provide. So you may have patients that require special medical accommodations to attend school. And they may have an IEP that allows an individualized education plan. And because of their specialized needs, they will require a medical accommodation to either get to school, to and from school. So for a transportation accommodation, they may require an additional support person, a paraprofessional. They may require home instruction, which is different, as Dr. Greer said, different than home schooling, where a teacher actually goes into the home and provides instruction for just a few hours a day. And or there may be a medical exemption. So we do want to just sharing that these are some of the medical accommodation reviews that are reviewed by our Office of School Health Physicians. The only caveat I do want to mention is that the immunization exemptions, the medical immunization exemption, can only be completed by a medical doctor. This is as per New York State. So I did want to just emphasize that. We do receive some from an NP, but unfortunately, as per New York State, we cannot accept those or process those. All requests for whatever type of medical accommodation are reviewed based on medical necessity, hence why we have our school health physicians that review those to ensure that there is an actual medical need. And our physicians will contact you to discuss the case, discuss the services, and better understand have a better understanding of the ask, and to be able to render a recommendation. Next slide, please.
So now we will talk more about how the Office of School Health has developed plans to provide clinical services when school reopens in the next few weeks. So the Office of School Health will use the same PPE guidelines that were recommended by the CDC for all healthcare providers who are providing clinical care, direct clinical care, including surgical masks, hand sanitizer, gloves, and face shields. PPE will be provided for all of our Office of School Health staff who are working in medical rooms in schools. Each medical room will have a non-contact thermometer, and all rooms must have mechanical ventilation, either mechanical HVAC system that delivers outdoor air or an operable window. Next slide. Next slide. So in addition to the medical room this year, we will each school will have an isolation room. This isolation room will be a designated space in each school building that is staffed by Department of Education personnel. Staff who are working in the isolation room must always wear appropriate PPE. The isolation room must meet the physical distancing criteria and provide distancing of 6 feet. As we mentioned, it must have adequate ventilation, either a mechanical ventilation or operable window. And while students are in the isolation room, they should wear a face covering and must remain in the isolation room pending disposition. Next slide.
So to evaluate students, there's a set of symptoms that will be used in the school building. And these we're calling COVID-like illness, we'll call it CLI moving forward. And these are the symptoms that will be looked at. Whether a student has a temperature of 100.4, axillary of 99.4, new onset cough, if they do not have asthma or some other respiratory diagnosis that would likely cause them to have a cough. So again, focusing on new onset cough. If the student has shortness of breath or chest pain or loss of smell and taste. Now we do know that students, children, pediatric patients don't always read the textbook, right? So they may not have all of these symptoms nicely packaged for us. So it's going to be a challenge. But these are the symptoms that we're going to be looking at. Next slide. If a student has CLI symptoms, the student will be sent home. A 12S, which is the form that is sent to parents, basically explaining what happened and advising them to be seen by their provider. The family, as I mentioned, will be advised to evaluate their child's symptoms, and also, again, if they have the CLI symptoms, be provided with a list of testing sites throughout the city and encouraged to get testing. No one can be, testing cannot be mandated, so they can only be encouraged. Next slide. So for student evaluation, if a student has a positive diagnostic test or is symptomatic and does not receive testing, because as I mentioned before, that they have the right not to pursue testing, they must remain out of school for the full isolation period. The major point, and which is one of the questions that came up a lot, as we previously, some of the earlier guidance stated a provider letter was needed, a provider letter is no longer needed for a student, one of your patients, to return to school. I just want to say that again. A provider letter is no longer needed for your patient to return to school. And we recognize it's a capacity issue to expect all of you to write these provider letters for your patients to go back to school. The next one, if a student is identified as a close contact of a confirmed case, possibly in the same household, a sibling, they must remain out of school for the full quarantine period, even if they receive a negative test result. And again, a provider letter will not be needed for your patients to return to school. Now, keep in mind, behind the scenes, if there is a positive case, there's going to be we have a tracing. Contact tracing is going to be monitoring, looking at all close contacts, ensuring who needs to stay home from school, who needs to stay. So all of that's going to be done behind the scenes. So know that the information will be provided to the families so they will know what they need to do next. So you will not need to write that letter. And lastly, if a student has symptoms and receives a negative COVID diagnostic test result, they can return to school if certain criteria is met. And that is still under development. As I mentioned at the very beginning, this is continually evolving, but these are right now the facts that we have. And so I just wanted to be able to answer that because I know this was one of the, a lot of the major questions that people, many of our community providers were having. Next slide, please.
So as pediatricians, we would be remiss if we did not have an anticipatory guidance section to our talk. We know that it's important to communicate with our students and our families, our parents, so that our parents can know what to expect and to prepare accordingly. So here is our guidance for returning to school in the midst of the COVID-19 pandemic. Next slide. So parents should have a back-to-school checklist just like they usually do, but with the following important additions. Ensure that your child goes to school wearing a fresh, clean face covering every day. As we mentioned earlier, face coverings that have exhalation valves are not allowed in school. In terms of packing their backpacks, be sure to pack an extra face covering. Ideally, those face coverings should be labeled with the child's name, and they should also have a personal hand sanitizer in their backpack so that it's easier for them to practice good hand hygiene. It's also critical that families provide the school with updated contact information and emergency contact information. This is essential to ensure immediate communication about their child's health, but also about any notifications regarding classrooms or school closures. Next slide. Also, counsel your parents to practice the core 4 at home. It's really important for them to model all the behaviors for their child so that their child will accept them and be more likely to implement them. And that includes reinforcing hand hygiene at home, talking about the importance of wearing face coverings and to practice wearing them at home, and to make it an engaging activity that the child can have ownership in. They should be able to engage and choose face covering colors or patterns that they find interesting and will be more likely to wear them if they're involved in the process. Advise children not to trade masks with others. We all know that if the Paw Patrol mask looks more interesting than the Spider-Man one, they might find it an easy switch, but that is not advisable in the face of this pandemic. And so this must be taught to children so that they know not to do their usual swaps. Advise parents also to monitor their child for symptoms before sending them to school. Again, one of the core 4 is to stay home if you're sick, and they should keep their children home if they are ill. Your child can only attend school if they are fever-free without taking fever-reducing medication. It's really also important to advise families to keep all medications in stock at home for your child, particularly children who have chronic diseases that need to be managed. This was one of the key concerns that we identified during our outreach during the early phases of pandemics, that some of our families did not have adequate supplies of albuterol or insulin, and we had to sort of make arrangements to ensure that those were available to them. As always, during these difficult times, we should be making every attempt to limit social media and news exposure for our kids. And you should be talking to them about COVID-19 in a developmentally appropriate way. Finally, always encourage families to ask for help and resources. There's a variety of resources out there, and we want to remove the stigma from asking for help, and that includes mental health resources. Next slide. in terms of them engaging with their children, always ask them what they're feeling and how they're feeling. It's important to acknowledge their fears and anxiety about returning to school in any learning format. And we've realized that some students may be anxious to return to school in person, but there are others who are engaged in virtual learning that may miss the direct interactions with their friends and teachers. Parents always know when their children are not acting normally, and they should monitor for behavioral signs of stress. And again, it's important to remove the mental health stigma and reassure your child that it's okay to ask for help and to seek mental health for them and for the family if needed. Next slide. And finally, we have anticipatory guidance for you, our community provider colleagues. We know that you have been on the front lines for the duration of this pandemic and the aftermath. And we all have to acknowledge that we've all been traumatized in some way by the pandemic, whether it be personally, professionally, or both. So while taking care of our patients and families, we may be vicariously absorbing a variety of experiences as we support them. And we may even feel at times that we're not doing enough. And this can be physically and mentally draining. And we have to allow ourselves the space for self-care and the ability to refuel and regenerate so that we can continue with our very important work. And so we encourage you to explore the various resources that are out there to find one that works best for you. Next slide.
So we've shared a lot of information with you so far, and to give you a sense of what schools would look like. We do want to make sure that you are able to assist families and provide reassurance that they do not need to send their children to school looking like this little one, and that we know that this is an evolving process. We know that we will have more information in the weeks to come. As we also continue to look towards the data, we look towards the CDC and New York State to be able to understand what our next steps look like. It will continually evolve and help guide us, but we do want to make sure that all of you are able to best support your families, and so that whatever option that they choose to go to school, whether it is in person or remote or a combination, that we just want to make sure that no child comes to school looking like that. Thank you very much. Next slide.
All right, thank you so much for that excellent presentation. So we have a whole lot of questions in the box. I think I will pick a few of them, but I think we'll try to figure out a way to share those questions with you, Dr. Lawrence, Dr. Greer, and we'll try to get some, we'll let you know in the upcoming weeks about the ways that we can get those answers back to all of the questions. I think we have almost 40 questions in the box, so we'll not get to all of those in 7 minutes. But I have picked out a few. I think one of the questions that we're seeing, I'm trying to summarize a couple of questions into one question, but so we have a couple questions on, asthma and other comorbid conditions, about co-infection, about, let's say if someone comes in with respiratory symptoms, how do we narrow down whether we think it's COVID and whether that child should follow all the protocols we talked about here?
So that's really going to be a clinical judgment call, because we have a nurse in every school, and we will have the nurse complete an assessment. And if there is any question that these symptoms are looking different than their normal symptoms, they are going to be encouraged to see their provider for follow-up care.
Great, thank you. And can you talk a little bit about return to school. And I know there are a couple different ways that you mentioned, or a couple different pieces of information. Can you just go through that step by step?
Which aspect? Because there's so many.
So let's say, what does the provider and the patient and their family have to do if they have had COVID, or let's just say if they were very ill and isolating at home? Can you sort of walk us through how they would get back to being allowed to go to school?
So it will all depend on what if they were sick. So I'm going to make the assumption that they were positive and it's a confirmed case. So if all of those pieces are in place, contact trace will evaluate the situation. They will determine whatever contacts that they have. They would have to isolate for 10 days and be fever-free for the last 24 hours before they're able to return to school. So those would be the pieces that the family would have to do. If the student is able to continue remote learning during that time, they will transition over to remote learning, and they will be able to continue their studies.
And what's the provider's role in that process in terms of, suggesting when to get a test, or in terms of, writing a note or an authorization so the kid can return to school and well?
So a note or authorization is not required by the provider. So what we would just say is that it is strongly encouraged that if a student has symptoms, has CLI, we do encourage them to get tested. So that is something that any of the providers could do, is to encourage their patients to get tested so that we can have a sense, nay or yay.
Okay, great. And let me see. I'm trying to pick the next question. You may not have the answer to this, but do you know what will happen around students who don't check in and don't show up for online check-ins for school?
So there are different types of check-ins. We have the clinical check-ins, and then we have the educational check-ins. So Department of Education is expecting to check in with families. And we do know that early on, some did not engage as well, whether or not they didn't have the appropriate devices. So there are systems in place to ensure that every student has the appropriate devices and they're able to do that educational check-in. Clinically, from the OSH team, we will continue to provide check-ins to students, again, prioritizing those that are at highest risk to ensure that they are connecting to all of you guys, the community providers, and because some people have retreated, and again, because of psychosocial concerns that may be affecting their family, we found that they just did not connect with their provider. So we've been encouraging that. So those would be the check-ins that would be happening moving forward.
Okay, great. And can you talk a little bit about what screening will be required, or what screening will be suggested around both staff and students?
So there is screening that happens prior to school. So they will be, in order for anyone to enter the building, a Department of Education building, they will have to complete a questionnaire, and it's a series of questions. It's very similar to the CLI. The only difference is what they're calling fever, and that is to prevent anyone from entering the building. It will be lowered to 100 as opposed to 100.4. But that information, that's the pre-screening to determine whether they can enter the school. And then, as we mentioned here, there is the screening that happens once the student is in this building, and that is to determine what the next steps are. And just so that you also know, well, at least from the Department of Education side, there is a whole series of determinations that are going to be done to determine, we alluded to it a bit, that whether a student is positive, whether a staff person is positive, the number of individuals will all make a determination on whether or not the school is closed or the classroom is closed, or whether or not they are moving towards remote learning as opposed to in-person learning. So all of those factors are going to play a role to make those next determinations.
Okay, great. Thanks so much. And I think we're at 2:30 now. We're actually 1 minute past.
Okay.
Thanks everyone for coming. And excuse me, as Allison mentioned, the slides and a video of the presentation will be available on our provider webpage, which is nyc.gov, which you can access through nyc.gov/health/coronavirus. And there is a whole section there for providers. We've also gotten some questions about data on the website or different pieces of guidance, and I really encourage you, there's a lot of good stuff there to explore it when you come to get the slides and watch the video. And as always, thank you for joining us. And then Allison, when is our next webinar scheduled?
We will be back in 2 weeks, Friday, September the 18th from 1 to 2 p.m. We hope you'll join us, and we will be updating that provider page with the registration link as well as sending it via email the week of. Thank you again.
Thank you.
Thank you.